Hi everyone, this is Dr. Dean. Dr. Taylor asked me to make a quick little tutorial before we meet tonight to talk about virtual visits. There's so many different things to talk about and potentially be confused about or to try to understand, and we're just trying to learn it too. So what I thought I would do is go through some of this so you can have it fresh in your mind a time or two, so that when Dr. Taylor's presenting it, you'll absorb it more, and then you can ask maybe even better questions, or you'll have a different perspective. Okay, so the first thing is that there are three types of visits that we want to talk about. Now, these are visits that are coming about due to the COVID-19 crisis. We're going to be trying to handle more patients through video portal or telephonic visits, as opposed just to calling everybody and telling everybody that they need to stay home and we can't see them. So that was sort of last week. This is sort of this week. So the video is not ready. It's still in the oven, apparently. So we'll touch on it, but we'll kind of center on the things that are going to make sense the fastest. And although we have a patient portal, we've got that going. We'll have to talk about some of that. And the telephonic visit is kind of a new visit, but I would foresee that the portal visit and the telephonic visit will probably be rolled out a little bit sooner, just because we don't have currently the technology all set. Now, they are telling us that if we wanted to do a video with a patient, we can use Google Hangouts or an app called Zoom. Now, the patient may not have video on their computer at home, and it's been my experience that they don't. But they could have Google Hangouts on their iPhone, and you could use your iPhone Google Hangouts app, or you could use Google Hangouts from your computer to interface with the patient on their phone. So so the patients could video conference you in that regard. The reason I put the smiley face here is that Zoom is a nice little app too, but it doesn't require permission like Google's Hangout on your phone. It doesn't give the authorities here at Ascension the authority to wipe your phone clean for some reason if you misplaced it. So that's the thing about Google Hangouts I'm not quite comfortable with. I downloaded it to look at it on my phone, but I've not activated it. So if any of you have insight, you can tell us what you found as well when we meet later tonight. I think Zoom would work well if you wanted to do that. There is a product that is supposed to be HIPAA compliant on Zoom. Zoom is a web app, and it's also a phone app. The patient would have to have the Zoom app on their phone, I'm assuming, but I haven't clarified whether the Zoom app on the patient's side would be HIPAA compliant or not. Now, they have acknowledged that it's not HIPAA compliant, but they're willing to waive it right now. But I think we still need a little bit of clarification, because Zoom website does have a product that's supposed to be for healthcare, and it is HIPAA compliant, so it's called Zoom Health. So again, we don't have that official product yet. So again, this video component is not yet quite established. There's another app called Amwell that's supposed to be coming for us, and that's the way that would probably work in the ideal world. So I think we have to be kind of careful about using some of these apps initially. You don't want to get your phone wiped, and you don't want to be using a lot of just apps on your own that's not going to be HIPAA compliant, and you might get in a sticky situation legally if there's some patient confidentiality that later on down the road, comes out. So I think we have to still be careful about that. Now, a video conference would be something that the staff would schedule as a patient encounter, and that would be documented by quite similar to the way we're seeing patients in the office now with our E&M codes. So in other words, this patient encounter would be a patient on your schedule when you're supposed to be seeing patients. So it's a good idea for you to keep checking your schedule, because these little encounters are going to be at some point in time showing up on your schedule. It's not going to be willy-nilly. It's still going to be during your office hours. These are the types of codes. I'm assuming these are the minutes that are supposed to be there for. But you would, encounter the patient virtually. I'm assuming you would ask chief complaint, review of systems, history of present illness, things like that. You would look at any physical findings on the video. You would, come up with an assessment and a plan and orders. And then you would bill for it either a 212, 213, 214. Now, we're used to doing 213s and 214s in the office, and sometimes 212s. The billing is going to be the exact same. And I'm going to go over billing in just a minute with you to refresh your memories on the billing. And because it's an encounter, the encounter will have a billing encounter tab for you to use. Okay, so there it is. Sorry about this little thing that keeps popping up. Okay, on the portal side, you can have a portal visit or a portal encounter, and this is when the patient brings in a message and it comes in as a portal message to you. Okay, so that is coming to you like it does usually now as a patient case. Now, this patient case is going to be coming to you, and if you're handling this message as a patient case, you're going to be documenting by time. And these are time codes down here. And I've created a handout for you. We can give you out this handout it kind of has all the codes in one spot. I think with every visit that you're going to do, a virtual visit, you probably need to, somewhere in there, maybe right after chief complaint or right before chief complaint, just get in a good habit of being a good doctor and document that the patient gives verbal consent to care. They've mentioned that throughout the handout, and I think it's just real important to get that in our DNA right off the start. This portal visit can't be related to anything you handled to that particular problem within the last 7 days. So it's got to be either something brand new, or it's got to be like if you just dealt with this thing a couple of days ago, you can't just keep doing portal visits over and over and over. Okay, and then the telephonic visit is sort of like what we're doing now, except you're either going to be up top. The way you interface with the patient here is you would either use the phone from the office, which you can certainly do, and I put a couple of apps here that you might want to look at. There's Perfect Serve, which gives you the ability to dial the patient's phone number, and they don't see your mobile number. But the reason I put a smiley face by Doximity is because it's a really cool app. It is a free app, and it lets you authenticate the office telephone number or any other number, like if you want to have an extension, on your phone. So in other words, you can dial their number from your phone, but they would see the office phone number as the incoming number. And in my experience, when they see the office number, they're going to be more likely to answer the phone call, number one. Number two, they're going to be less likely to delete it just because they think they're being spammed by somebody that they don't know. So I really like Doximity there. And the third reason is that Doximity, if you leave a message, the patient knows the number to call back if if they know the office number is the number to call back to. There's a bunch of other cool things I'm going to show you. I'm going to show you some examples of Doximity if you've not used it, just a few cool ideas about it. But in general, the telephone visit, we're calling it a telephonic visit. It's another patient encounter. So the only one that's going to be a patient case is the portal, which kind of makes sense because the portal is where we generate patient cases anyway. But this telephonic visit, the patient message would come in, they would create an encounter, and when you interact with the patient in a meaningful way, in other words, when you're managing a medical issue, you're not just saying, hey, how you doing, Uncle Joe? If you're managing a medical issue, you're going to bill for your services by the time you spend with them. Okay, so again, the things that are in common are the video and the telephonic. These are encounters. So you're billing using the billing encounter tab. Okay, so that's similar. The things that are similar on the billing side otherwise is the time. The portal and the telephonics are by time, but notice these codes are different codes. And the thing that is similar in your own mind of what you're used to is that the video conference has the same familiar codes that you're used to already. Okay, so let's move on and let's take a look at some examples of a telephonic visit. Now I'm using telephonic first. This is our visit over here, telephonic visit. I'm using that because it's probably the most familiar and the most likely one of the first visits you're going to see. So Granny calls in to the phone staff, and the phone staff takes a message, okay? We're walking through every little thing because there are many of us out there who like to know every detail on this, and it makes us think it through even better. So then you can think of some things to ask tonight for questions. So Granny calls, phone staff takes the message, she creates a patient encounter, just like we said, there's a patient encounter. She creates this patient encounter and sends it to you, okay? But it's on your schedule, okay? So we're sort of letting the judgment go to the phone person. The phone person's, Dr. Taylor's going to go into this more, but the phone person, when they receive this call, if it sounds like management's going to be needed, they're going to be scripted to say, okay, Granny, would you like us to schedule you a time to see the doctor? And Granny's going to go, whoa, this is new. And they're either going to say, oh, I don't think so. I think it can wait till later. I'll wait till I see the doctor. Or they're going to say, well, you know what? This is the new era. The doctor's going to see me on the phone now. So now they create a patient encounter for you. It's on your schedule. So when you come into the office, you're going to look at your schedule and you go, oh, Granny's on my schedule. I'm going to call her, and I believe that's going to be at the appointment time. That would make sense to me. And again, the first thing you're going to do when you say hey to Granny is get verbal consent to care so you can document that. And then you're going to talk to Granny just like you usually do, but you're going to remember that this is an encounter. So you're going to want to formally ask the chief complaint. Why? Because the chief complaint has to be documented in the encounter just like you do now. HPI, same thing. ROS, same thing. You're going to still go over Granny's medicines, allergies, past medical history. You're not going to examine Granny. Why? Because she's on the phone. Okay? So you're still going to generate an assessment and a plan in the encounter, generate some orders if you need to, and then at the conclusion, you're going to build this encounter using the encounter tab. Why? Because it's an encounter. And the thing about this is you're going to bill and you're going to document by the time you spend with Granny. Okay? So these are the different codes that we're talking about up here. You're going to be billing by your time. So it might be wise for you just to Xerox a bunch of these and just leave it around so when you're in your office you can remember this. If you're a resident, we're expecting you to call Granny when you're in the office. We're not really going to be expecting you to call Granny at nighttime. Why? Because you're not in the office at nighttime. Now, if there's an emergency call, you're going to have to call Granny back or whatever. We get that. But the way it's been presented to me is this is like office time for you, so use your office time to call Granny at the appointed time. And then you're going to send the note to the preceptor that's on duty when you made the phone call. So you're going to have a preceptor, and you might precept the case, let them know. We haven't talked about this as a faculty yet, but it would seem reasonable to me that there's a preceptor on duty. We can call them, it's a virtual preceptor, the VP, or however you want to refer to the preceptor. They're there, and you can talk, and you can send that to them. What does a portal visit look like? Okay, so this was our middle one here. Okay, portal visit. Okay, this person, she's at home and she's pecking away on her computer because she doesn't want to make a phone call. She's too new age. So now she is sending a message through her computer. It comes in as a portal message. The phone staff is lined up to take the message, and it's going to be, because we're trying to streamline, there's going to be someone that's all they're doing is just this stuff. So hopefully, if you've been someone who's been experiencing a 1 or 2 or 3 day delay on getting your messages, hopefully that will be tightened up as well. So you're going to be getting a message from your patient in your box, in your Athena box, okay? And they're going to create this as a patient case, okay? This is not an encounter. It's not going to show up on your, like an appointment. This is a case, okay? Because it's a message coming in through the portal, because it's just like it's doing now. So it goes to your Athena inbox. You're going to look at your box. You're going to read the message, and you're going to decide what you're going to do about it. So either number one, you're either going to handle the issue, because it doesn't need to be billed out, right? Just like you're doing now. Oh, Granny needs a refill. Peck, 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 peck. Goes over here, gets to you. I'm going to refill it. Boom, done. Close it just like you're closing it now, or whatever you do. But if you decide that this needs to be a visit, okay, you need to handle the issue with the billing side. And the way this is presented to me, and Dr. Taylor will probably clarify more, you would want to reply back to the patient in some way. Would you like this to be a portal encounter? Okay, and if so, they give you verbal consent. Then what it looks like is you're just going to answer their situation or their question, okay? And you might have to flip-flop back and forth, to get an answer. You might just say, okay, Grandma, your blood sugar's 300, tell me what you've been eating, or something like that. And you send it back, and she goes, well, I've been eating, chocolate milkshakes. And then she sends it back to you, and you say, well, Granny, you need to stop doing that. You send it back to her, and then she says, oh, okay, thanks a lot. And she sends it back to you. And I'm thinking that's the way this is going to look. And so you're going to be billing by your time spent. Now, this is, from what I've been able to see, this is cumulative time spent. Okay, so the cumulative time that you spend dealing with all this, you're going to estimate, and hopefully you'll be able to take care of this maybe the first go round. But that's the way these codes work. So these are the codes. So we're coding by time spent on this portal visit. And if you decide to bill out from this portal visit, from this patient case, remember, this is not an encounter. There's no billing tab on a patient case. So according to Dr. Taylor, we send this case to T. Collins, one of our staff, I believe, who, and with the proper billing code. Okay, you need to have that billing code, and I would assume you want to document that you've had a verbal consent for this kind of care. You document the problem and what you do about it. And remember, this is not an encounter, so it's just going to be in this little patient case text box, okay? So make sure it's thorough, but it's not the formal thing that's going to happen when you do an encounter. Now, again, residents that are doing this, I'm thinking the way this is going to work, and Dr. Taylor will clarify this, but we're trying to think of the residents would be sending it to the preceptor on duty approximately when you're handling this. If you're handling stuff in the office, obviously there's going to be a preceptor on duty. That would be the ideal way. If you're doing this at night, let's say you answer the patient case maybe in the afternoon, you send it to grandma, and then she sends it back, but you don't get it till later that night, and you want to be a really efficient resident, and you answer grandma at night. Who do you send it to now? Well, it makes sense that you would send it to whoever was on duty, I would think, earlier that day when you were in the office and were handling it. That's probably something that we can talk about more as a faculty. Okay, so that's portal visit. Let's talk about the telephonic visit. So, oops, you know what? I messed up. The video visit is what I want to talk about next. This should not be telephonic visit. This is a video visit. And that lady right there is so mad because she knows I messed up. Okay, so a video visit is basically going to be the phone staff takes a message just like usual. Here we are over here. Video visit comes in, message comes in, and they create an encounter just like they did with the telephonic visit. Okay, so video visit, they create a message, they create an encounter, and they stick it on your schedule. All right, so now you've got a virtual visit, okay, with a patient at an appointment time. Okay, same thing with telephone. So you may have a telephone here and a virtual visit somewhere else in your schedule. Again, I would say make sure there's a verbal consent to care, and then talk to the patient as usual. Again, chief complaint, HPI, ROS, your usual thing. Generate an assessment and plan and some orders. And again, with the virtual visit, just like just as we did with the telephonic visit, we're going to bill using the Encounter tab, which is inside the patient encounter. Now this one, the virtual visit, just notice we're billing out by E&M codes with a VV modifier. Okay, VV, what do you think that stands for? Virtual visit. Yep. All you guys, you're just dead on. Okay, residents, then after your virtual visit, send to the preceptor on duty to, I would assume that's what we're doing, to co-sign the visit. And I think maybe Dr. Taylor will clarify that we would either close out the visit or then sign and then send back to you to close, as we do on our regular office encounters. Okay, so we have reviewed the 3 types of virtual visits: the video visit, the portal visit, the telephonic visit, and we have also said that the video visit, don't you love it? The video visit and the telephonic visit are going to be patient encounters, unlike the portal visit, which is a patient case. And we have said that the video visit is going to use these E&M codes with a VV modifier, like what we're doing now with our the closest thing that we have to a real visit. The portal visits and the telephonic visits are billed out by time. And again, the video visits and the telephonic visits, because they're patient encounters on your schedule, you're going to be billing using that. The patient case is going to be sent to office staff, and they're going to bill out by hand, okay? Now, the important thing to remember about E&M visits is that, and this is the codiology worksheet that we use at Southfield, at Dayton, and that we've talked to the Southline staff as well about, but this is what we use. Just remember that the visit for an established patient is composed, the bill is complexity of medical decision-making, history, and the exam, okay? Now, for an established patient, you only need 2 of these 3 things to bill for services. So that's why, in my mind, we can bill a 213 or a 214 because you really only need complexity of medical decision making and history. You don't even need the exam part, okay? And that's why this thing over here flies, because you haven't examined the patient, but you're still getting the 214. If there was anybody out there, if that was messing with your brain a little bit, just remember, for an established patient, the 214, you only need 2 of these 3 factors. Now, if it's a new patient, you got to have an exam. 3 out of 3 components of the bill, of the code, are required. So I don't believe at all we can do a virtual visit on a new patient. And you can see right here, it doesn't make any sense because you've got an exam is required. So really what we're talking about is an established patient. 2 of the 3 factors are needed. And remember, we've been training you guys to do all 3 anyway, just for completeness. But in reality, only 2 of the 3 are even necessary, which is good. But you're being trained to be super duper complete for your inpatient, for your in-office visits, because you're doing all 3. Okay, so again, remember your risk, remember your data, remember your diagnostic management, and that helps you calculate your complexity of medical decision making, and you'll be able to decide if it's straightforward, low, moderate, or high. Let that generate your code rather than trying to count bullets over here. This is ethical. So if you've got a patient on prescription medication, and if they've got a new problem or a new problem, no additional workup needed, whether it's workup needed or no additional workup needed, that's either going to be a 4 or a 3. With a moderate, a 4 or a 3, it's going to be moderate, a 214. If the person has 3 or more established problems that are doing well, that's 3 points for each of the established problems. That's 3 points, plus your prescription medicine is still a 214. If one of the problems is poorly controlled, they get 2 points. And if one problem is stable, you get 1 point. Poorly controlled diabetes is worth 2. Stable hypertension is worth 1. That's still 3. With prescription medicine, a 3, and a moderate is a 214. Okay? So these virtual visits, now assuming the virtual visit codes are the same, and I have a sneaking suspicion that this code probably is not as valuable as a 214 in the office. I'm not sure about that. We'll see how that goes. But that's probably what you would want to do if you were in private practice. You would probably want to generate as much of these higher level codes as you could for all these people running around with chronic problems. Now, the way this is most likely to occur is they're going to be calling us over the next month or 2, hey doc, I have a cough. Okay? Hey doc, I have a cough. That's a new problem. That's 3 right there. All right? Hey doc, I have a cough. And you say, well, okay, how bad's your cough? It's pretty bad. All right? So if you decide, remember, you can order an x-ray from the office and send it, and they don't have to come to the office for you to listen to their lungs. If you can hear it, blah, blah, you can hear it, you can order the x-ray or labs. So a new problem needing a workup would be 4 points. Hey doc, I got a cough. Okay, we're going to get a chest x-ray. Hey doc, I got a cough and I got a fever. All right, well, you know what? We're going to I can order a CBC if we need to. Or I got hey doc, my diabetes is bad and I haven't been checked in a while. Okay, I can order a glycohemoglobin from the lab. Or hey doc, I've got chronic kidney disease. I need some follow-up. So let's just say how that would go. They say, hey doc, I have a cough. Okay, well they'll handle the cough. Take some Mucinex. Oh, but by the way, while you're on the phone, I've got my diabetes hadn't been checked. Okay, well I can order something. And if it's on your schedule as an encounter, these codes add up and you can start adding in the new problem that doesn't need a workup because the cough doesn't need a workup. And then you can throw in an established problem that's poorly controlled, which is diabetes. That would be 3 + 2 is 5, and it only goes to 4. But you can see that if it is a video visit, your E&M coding comes into play. If it's more of a telephonic visit or a portal visit, you know, and they ask you the same kind of questions and you order the same stuff, you're just going to be coding by your time. Okay, I hope that makes sense. And now just remember, I'm sorry to be flipping around, but the guidance they give you down here in the handouts, that you'll have to have straight, like a 214's moderate complexity to medical decision making, history, and your physical exam is detailed. Again, history, detailed history means you need greater than or equal to 4 of the HPIs, or you could say 3 chronic conditions. Okay? ROS, detailed, 2 to 9 for the ROS. Past medical, family, social, you just need 1. Okay? You can forget all this stuff over here because you're not examining. All right, well, I hope this is a little bit of a refresher for the E&M side of this, but otherwise for these, for the portal and the telephonic, we're coding by time. Now, just a couple of quickies on this. Doximity, you can call patients using your mobile phone. This is the website, and just helps me remember to let you know that it's for Android or iOS. And I just got a message today that they were opening up the service for office staff to relieve some of the phone call burden on people trying to call patients back. So we're looking into that for some of our office staff if they need to do this too. These are some screenshots from my Doximity app just to show you if you've not seen Doximity. You know, one of the screens is just a telephone, and basically it shows you, there it is right there, there's our office number, and you can add another ID if you have an extension at another desk. You can add as many extensions as you want. So you just basically dial in the patient's number, and what will happen is then you will press this button, and it'll generate an internet number that calls the patient but shows the patient this number. Now you can decide to call the patient straight away and talk to them. Now it also gives you a lot of flexibility because you can hit this button and send a message, and the phone on the patient's side won't ring, and you can just do a voicemail. So if you just need to touch base with somebody and tell them you did something, you can send them a straight to voicemail something. You can tell them that you'll call them back or touch base if you want to. And then if you want to text the patient, you can also text the patient, but they won't see your phone number again, so you can send a text. And I'll show you what that looks like. So when you dial this, you dial the patient's number, you press the green button, you want to talk to them, it'll say you're now connected by this number to the number below, and you just press call, boom, okay? And then what happens is you make your phone call, and then after your phone call, you just hang up, but if they don't answer, it can give you the ability to leave them a text message. So you can say, I just left you a voice message on your phone, send it. And that's really, really cool because they just got a voice message on their phone and a text message on their phone from you. And then Doximity gives you the ability to have some automatic texts here, like an appointment reminder, so you don't have to do a lot of typing. Office directions or business card, you can send that automatically, or this thing here called custom text, which I use every day. Every single patient I call that doesn't answer, they're going to get a text. So I preferentially call on their cell phone first because they're probably walking around with their cell phone. And number two, if they don't answer, they're going to have a text on their phone from me. LastPass. Dr. Taylor hasn't seen this one, and I told her I was going to throw in this just because I'm about being driven crazy with all these passwords, you know, and maybe you are too. So this is my solution that I really love. And you know what? When I was making this video, I didn't even prepare to do this. So you're going to see me do this, if I can pull this off, like in real time. So what's LastPass? it's a browser extension. So you're not really installing it on your computer, you're installing it in your browser. And that's cool. Why? Because we can do it on the computers without having IT have to come down and do anything. And it'll work on Chrome or Firefox or Internet Explorer or Safari or I think that's Opera. So, but I just use it on Google Chrome. So it's a browser extension, and basically you make one password for LastPass, and then when you get on your computer, all you have to do is sign on to LastPass, and it's ready to go. What's that mean? That means all of the passwords that you have to enter over and over, this thing remembers it, and you can sign into your LastPass website, and it's got all these different sites that you go. Some can be business, some can be personal. There's a free version of this, there's a paid version of this. I got the paid version because it'll let my wife create an account and sign on, so she has all of the passwords that I sign on to, so that if something happens, my wife could sign on and get to it. But if you're a resident and you just want to do it for free, it's all free to go. So let's talk about this is my LastPass. It's got a lot of stuff, but let me just show you what this looks like. So this is my LastPass right here. Okay, and if I wanted to open it up, just to show you, this is my LastPass. It's got a whole bunch of stuff in here. So let's just say I wanted to open up my Google account. Okay, so I can do it so many ways. But if I just type in Google, okay, there's all these Google accounts. I can't remember all these different passwords, but there's the Google account for the Ascension. Okay, so it just does that. Look how fast this thing is. Boom, boom. Okay, and I don't have to type it in. That just saves me some time. So now I'm in the Ascension Google. Let's say I wanted to open up. I don't have to open it. Let's say I wanted to open up. My personal Google. Okay. Let's see. I'm doing this under pressure here, folks. Let's see here. There's my Google. Okay. So there, see again, I can choose the account I want. And LastPass remembers the password. That's my personal Google. There's that. And any site that I want to go for, this LastPass will just remember it. And there's, you can have favorites, or, like for when we're doing all that new innovations and just different sites. I think this really helps me. So for better or for worse, there's LastPass. So I hope this was helpful to you as we study and as we try to learn more about these virtual visits. So now I'm going to stop the presentation and just encourage you to think about all this, and we'll meet later tonight for Dr. Taylor. Thank you.